is about the use of maternal and perinatal death surveillance and response, mpdsr, as a quality improvement tool in Nakuru County. Why am I looking at quality improvement? I want to share this paper as a success story as a trained mpdsr assessor. The experiences that I've gone through being a trained assessor, the experiences that I've gone through as a practicing midwife. The sub-theme to this presentation is empowerment of the nursing and midwifery workforce for UHC agenda. Having listened to our presenters yesterday, mpdsr was talked about so much, and just to punch on it, I'll give you a bit of information about Nakuru and the innovations that we as nurses have embraced, the new things that we've done as nurses, purely nurse-driven, to help, or rather to help in mitigating the maternal deaths and perinatal deaths. What is mpdsr? mpdsr is a form of continuous surveillance that links the health information system and quality improvement processes from the local to the national levels. This mpdsr resulted from the Global Strategy for Women, Children and Adolescents Health, that is the 2016-2030, that seeks to end preventable maternal, newborn, child and adolescent deaths and stillbirths as well. The main aim of mpdsr is to provide guidance on how to conduct reviews of maternal and newborn death and stillbirth as well. And remember the near misses. Sometimes when we talk about mpdsr, people think about only maternal deaths. But remember, we do so much and save many lives as well. So mpdsr is about the maternal deaths and those near misses, the mothers who we are able to save and they don't get to die. So I was saying, as well as near misses at both facility and community levels, eventually giving feedback on indicators or avoidable factors with a clear response to avert future deaths. The key word there is a response to avert future deaths. In Kenya, an mpdsr framework is in place. There is a national secretariat which coordinates activities. County committees also are present that coordinates activities at the county levels. The problem, as mentioned yesterday, the maternal mortality ratio, I think there's a typing error, is 362 per 1,000 live deaths. And for us in Nakuru, interventions are there, but we still remained high. The last one we were at around 394. And so we wanted to comp our data and try to seek to find out why is it happening so. The methodology, we used a mixed approach where we were analyzing the data available in our DHIS. We also looked at documents, the case files, and we also looked at qualitative data through interviews to key informants. And the key informants, we purposefully selected them. What are the results? The results that I have here are so sketchy, but we have so much into this. Like here we have the maternal death files audited. Our N is 49. And by N, I mean the mothers who died last year from pregnancy and pregnancy-related deaths, that is. So for the ones who died, in 2018, we were able to audit 96%. But currently, we audited 94%. there is an improvement of all the files audited. Initially, before mpdsr was in place, people used to fear. When a mother dies, you'd be called for a committee. You'll be asked, what happened? And some of those files will disappear. They will disappear to the places you all know about, for those who've worked in labor ward. Those files would be doctored. All of you know that. But after the mpdsr processes were put in place, there is so much, people have become receptive. Auditing of those files has really improved. And as for us in Nakuru, there is an improvement. There is up from 76 to 94%. And to note here, in PGH, which is our main referral hospital, being a busy hospital with around 1,200 plus deliveries in a month, we are at 100% audit, meaning we audit all our maternal deaths and near misses. On utilization of pathograph, which is a best practice, there was a survey which was done by the national government using the EMOC assessment tool, and in 2018 we were placed at 40%. What happened in 2019, which was done 2 months ago, there was an improvement of the use of pathograph to 88%. There is a criteria using that tool to assess the utilization of pathograph and other EMOC activities. In delay in healthcare, of all the mothers, our mothers who died, 41% of the deaths were primarily in the first delay. By the first delay, I mean those factors that are associated with the patient. Maybe the patient delayed to make decision to go to the hospital. Probably she was ignorant of the available services. And lumped together, we had a 41%. And the second delay, that is accessibility from the facility, that is transport and infrastructure, we were at 23%. The third delay, where we all are, we are at 36% as a county. Some of the qualitative results that we found out when we interviewed key informants, one of them responded by saying it was very difficult. It was a very difficult task retrieving maternal death case files for the confidential inquiry into maternal deaths reports initially. But now everything has really improved. If any case file is requested for, it is easily traced and retrieved. Another theme that emerged is from another respondent was that the number of health workers attending our mortality meetings has increased, unlike before. We now have all cadres. We have MOs, we have nurses, we have lab techs, public health officers, health record officers, administration representatives, we have students, and county health officials. There is no intimidation like before. There is feedback to the sub-counties are given upfront, end of quote. In conclusion, and that is my punchline, we came up with good clinical practices, and I picked a few among many. The first one is that we have a functional mpdsr committees at all levels of care. At all levels, I mean the level 1s, the dispensaries, the communities, and up to the level 6. The other innovation is that we've embraced the utilization of uterine balloon tamponates, that is UBT, for suitable cases. Remember, everybody who gets PPH does not qualify to use UBT. So for the suitable cases, we are able to use UBT because most of us were trained by KMET, and for those who are not trained, we are able to mentor them. And another good practice that probably we should share in your places of work is that we have a strengthened referral system. Why strengthen? Because we are able to invite referring facilities to our audit meetings. They are given feedback, and we have a good communication channel. We have a good communication channel because in our county we have subunits, the county subunits, and we have a WhatsApp group for all the facilities. And when, in case of any relevant information, we are able to give feedback immediately. On top of that, when we are auditing a maternal death, probably the mother came from this dispensary through a sub-county hospital to our major referring facility, that is Margaret Kenyatta. What happens when we are auditing that case, that maternal death case? We have all the representatives from those facilities to the meeting, so that we together try to really come to find out what might have caused this maternal death, so that we try and avert future maternal deaths. What else are we doing in Nakuru? We are also doing community autopsies of the maternal deaths that occur in the community. We also do CMEs and drills on obstetric emergencies. And there is improved documentation. That is according to the survey that was done by IMOC, National Assessment Team. And that is on the use of pathograph. There is improved, from the qualitative data, we can say there is an improved management of handling the maternal death case files. No more hiding. Since they are sensitive, in quotes, the maternal death case files are sensitive files, so they are kept and one person is designated to keep the files. Another good practice that probably you should take home if you are not practicing is a partnership with teaching institutions for specialists. Most of the deaths, we realize that they die they die having not been seen by specialists. This is a mother who comes in. A mother probably has been seen by an MO, probably needed a gynecologist or an obstetrician's care. And because of the human resource factor, the patient is not able to be seen by the specialist. So what are we doing? We've partnered with teaching institutions for specialists, and actually they are actually put to cover most of the shifts. So we have 24/7 unit coverage by the senior most specialists, that is obstetricians and gynecologists. And also, for talking about partnerships, we've also partnered with private institutions for resources. For example, blood and blood products. We have a regional blood bank. However, sometimes we might lack a certain blood or blood product, and is available in a private facility. So we have that partnership with the private institutions to ensure, or rather to try and avert any maternal deaths. Infrastructure like ICU, because sometimes we've had patients who've been recommended for ICU care. Our ICU, you know the ICUs that we have, the beds, getting a bed in the national level sometimes is a bit tricky, and we've heard about litigations and the human rights. So what we've done, since we have private hospitals with ICUs around, we necessarily don't, we have an MOU with them to admit our patients without necessarily having to pay the down payment. Normally they are asked for 80,000 before you're booked in for a bed. So what we are doing, we've partnered, and all our patients who come through our public facility, they go to private institution without having necessarily to pay the down payment. Another factor which is also interesting is mentorship and training of students and young nurses, because this is a group that has remained useful, especially in the out of working hours. What normally happens in the evenings, when we audited our files, we found that most of our maternal deaths occur out of working hours. They occur out of over the weekends. That is, and looking at the type of human resource that we have during those times, we cannot overlook the role of our young student nurses. So, and they also have a role in human resource. And for us, we've mentored them. We've also mentored the young nurses as well. And when we are doing duty allocations for the staffs that are available, we make sure for each shift we have a senior nurse in the ground or a senior midwife to coordinate the activities so that the skill factor is taken care of. So for us, we find that as an innovation. There is no other time that you'll find new nurses taking care of the shift alone. And recommendations that we have, there is need to put up in place systems to monitor and evaluate the action points made during the assessment. We make very good audits. We come up with very good recommendation. Apparently, we sometimes do not have proper systems to monitor and to provide M&D on the said actions. We could suggest and just left there. So that is one of the recommendations. And also, if Dr. Rai was here, he would agree with me that more research into reasons for delay in seeking health. Why are these mothers or why are these clients staying at home for that long before seeking or making decisions to come to the health facility? And it will also explain why we are having the indicator on the 4th ANC visit doing so badly in our country, and it is the worst also in our county. So we appreciate KMET for educating us on UBT, LSTM, the Liverpool School of Tropical Medicine, who trained me on mpdsr and gave me a different lens on how to look at the mpdsr activities. So that is it. If you keep on doing what you have always been doing, you will keep on getting what you have always gotten. So let's think, let's innovate, and come up with how to manage our mothers differently. Thank you so much.
Thank you.